Yeah, okay. Thank you so much. So this talk is on optimizing the use of Uterotonics in the management of postpartum hemorrhage. And we took up this topic because labor room protocols, management of postpartum hemorrhage is a very, very important part. I would like to thank Hema Divakar madam and Dr. Hrishikesh Pai sir for the opportunity, as well as the Manyata team with Samita and Sanjana. And at the top, uh, when you want to talk about PPH, we need to know that it is one of the most important cause of maternal deaths in the world. And according to the World Health Organization, almost 14 million patients suffer from postpartum hemorrhage every year, and that contributes to almost 70,000 of the deaths of mothers globally. And that's a big, big number. Uh, what do you actually mean about postpartum hemorrhages? Any bleeding after birth of the placenta, and that is after the third stage of labor, which is actually the delivery of the newborn until the delivery of the placenta. There's the fourth stage, or after the third stage of labor. It is the most unforgiving stage of labor, and it there lurks more unheralded treachery than in both the other stages combined. You can escape in a latent phase, you can escape in an active phase, but after the third stage of labor, that is after the delivery of the placenta, there is a time period, and that is the golden hour, which we say it's one of the most important parts of labor. And a patient who's delivered normally can within a minute can go for an abnormal presentation, and a successful delivery can actually turn very swiftly to disaster. This is not said now. This has been said for centuries, and this study was actually presented in 1978. Uh, and what is the most important component of management of the third stage of labor is the active management, and that is the first part is the administration of the uterotonic. That's most important part of the third stage of labor management. And the uniform guidelines is you give injection oxytocin 10 units IM immediately after birth of the baby. We were giving it at the delivery of the anterior shoulder, but you can give at the delivery of the birth of the baby. And then the second step of active management is once the uterus is contracted and the cord has been cut, you need to do a controlled cord traction where you remove the placenta. You pull on the cord and give a counter traction with the other hand so that you avoid the uterus inverting. So that's a very important part. Wait for the placenta to separate, and then you will remove the placenta under guidance by a hand on the abdominal wall. And third part is the uterine massage to keep the uterus contracted. But the most important part of active management of third stage of labor, where you avoid a postpartum hemorrhage, is the uterotonic, and that is oxytocin injection at 10 units IM. And you need to administer the uterotonic within 1 minute of delivery. There are different agents which have been advocated for the active management. And the first is oxytocin 10 units intramuscular, because it's one of the easiest to be given with very less side effects. And if the team is well versed with a intravenous technique, they can give a 5 international units of oxytocin, but dilute it to 5 ml. They cannot give it as a push directly as 5 international units, because it can cause severe hypotension in certain mothers. And you have to dilute it to 5 ml and then give intravenously over a 1 minute time. Other drug which is not so actually practiced is misoprostol, which is 400 to 600 microgram orally. But the drug which is now been available in the market is carbetocin, which is a 100 microgram intramuscular dose. Also can be given as a slow intravenous dose, but has to be diluted like oxytocin to 5 ml and given over 1 minute. Whichever is comfortable and whichever has been practiced in your unit, you can give, but give at least one uterotonic within 1 minute of delivery of the baby and the placenta. Regarding carbetocin, it has been recommended for the prevention of PPH. It cannot be given for the treatment of PPH, because there seems to be a confusion that clinicians think that carbetocin can be given for the treatment of PPH, but it actually can be given only for the prevention of PPH. The advantage of this drug is it is a heat-stable molecule. It does not require refrigeration, and hence it will eliminate the cost associated with having a refrigerator in a center and the transport form, not heat-stable uterotonics like oxytocin or carboprost. Carbetocin can be kept at room temperature, and that is the advantage of this drug. WHO says that there are certain drugs which are not recommended for an active management. That's for a prophylaxis of bleeding. You don't need to give these drugs, and that is methylergometrin injection, prostaglandin F2 alpha, or carboprost. The reason is there are much safer options available like oxytocin and carbetocin. So it's better that you don't give the drugs which need to be given only for the treatment of PPH. So when you want to define postpartum hemorrhage, any blood loss from the mother which is equal to or exceeds 500 ml in the first 24 hours after birth, it is defined as postpartum hemorrhage. It becomes a severe category when the loss of blood is greater than or equal to 1 liter or 1000 ml in the first 24 hours of birth. So it can be a mild PPH or a severe PPH. The etiology of postpartum hemorrhage can be remembered with the mnemonic 4 T's, and that is tone of the uterus, any trauma to the genital tract, any tissue left behind like a placental bit or a membrane bit, or thrombin where there's a coagulation deficiency. But the most common cause of postpartum hemorrhage anywhere in the world is atonicity of the uterus. It contributes to almost 70% of the cases. Trauma of the genital tract contributes to PPH as 20%. Tissue being the reason for PPH is around 10%, and thrombin causing PPH is 1% of the incidence. For the treatment of atonic PPH, the first mode of management is always drugs. And these drugs should increase the uterine contractility. It can be oxytocin, it can be the prostaglandins, or can be the ergot drugs. But if there's no response to uterotonics, you need to move to the second line of treatment for atonic PPH. That is, you can use a balloon tamponade or a suction cannula. And suppose there's no response to uterotonics and then the sequential management with balloon tamponade or suction cannula, please go on to the stepwise surgical treatment. The drugs which are available for contracting the uterus in hemorrhaging patient is oxytocin, ergometrin, misoprostol, and carboprost. Regarding oxytocin, this drug requires a special storage requirement, and that is around 2 to 8 degrees centigrade. It needs to be maintained, and you need to give multiple doses to manage PPH because it's a short-acting drug, and that's why these multiple doses are needed. And suppose you overdose the mother or give oxytocin for a prolonged period of time, it can lead on to auto intoxication. And sometimes the prolonged use itself can cause the uterus to uterus not being responsive to the drug, and she may actually go on to uterine atony when you keep on giving the infusions. Regarding ergometrin, it also needs a special storage conditions around 2 to 8 degrees centigrade, and it is associated with significant increase in side effects like nausea, vomiting, and an increase in blood pressure. And it needs to be avoided in patients who have got a hypertensive disorders in pregnancy, which includes chronic hypertension. Misoprostol is a third uterotonic which has been advocated, and this drug has got more side effects compared to the other drugs, and it can be in the form of shivering and pyrexia. It is associated with the higher risk of severe PPH and increased use of additional uterotonics. That is, misoprostol may not be enough as a single drug to manage a patient who's got a severe PPH and may need additional uterotonics to get over the crisis. And it has to be used with caution in patients with cardiovascular disease. Regarding carboprost, it also requires special storage conditions around 2 to 8 degrees centigrade. It is associated with side effects like vomiting, diarrhea, and bronchospasm, and cannot be used in asthmatics or a patient who's got a significant renal, hepatic, or cardiac disease. The new agent carbetocin is, it has been emphasized that it should be used only for the prevention of PPH as a part of active management of the third stage of labor. This drug is a long-acting synthetic analog of oxytocin with agonist properties. The molecular structure is different from oxytocin, and that's why it can be stored at a room temperature because there's an enhanced stability. And it also has lower affinity for the vasopressin B2 receptor, and that's why the fluid overload, the water retention which happens in oxytocin may not happen with carbetocin. This drug has got a very rapid onset of action within 1 to 2 minutes, and that's why it is used for the active management of third stage of labor. And the drug will work for 1 hour approximately after the injection is given. So for 1 hour, you need not give any other uterotonic if the bleeding is not there. And the safety profile is totally comparable to oxytocin. So how do you use these drugs when the patient is hemorrhaging? That is, active management, the use was 10 units of oxytocin IM. But when you want to manage a patient who's hemorrhaging, is landed up with postpartum hemorrhage, when you give oxytocin, you have to give it as an infusion. Take a 1 liter IV fluids, which can be normal saline or RL, and add 20 units of oxytocin. Keep it at 60 drops per minute. And then once bleeding has come down, you can reduce it to 40 drops per minute, but at the same dose of 20 units in 1 liter of IV fluids. But you cannot give more than 3 liters of IV fluids containing oxytocin. Infusions beyond 3 liters should not be given. And you should not give an IV bolus of oxytocin because it can cause severe hypotension. And regarding the ergot alkaloid, ergometrin or methyl ergometrin, it can be given as an intramuscular or a slow intravenous dose. The dose is 0.2 milligram. And you can repeat it if the bleeding is not stopping, but you cannot cross 5 doses, that is total of 1 milligram. And you have to give it every fourth hourly. You cannot repeat it often. And regarding 15-methyl prostaglandin F2 alpha carboprost, it's given only as an intramuscular dose, and that the dose is 0.25 milligram. But given every 15 minutes if the bleeding is not stopping, but you cannot cross 8 doses, and that's a total of 2 milligram. And when you give oxytocin as an infusion, remember that the onset happens in the next 2 to 3 minutes, and it can last for 15 to 20 minutes. Side effects are quite minimal compared to the other drugs, but a direct IV oxytocin push is contraindicated, and you cannot give an oxytocin IV definitely in a patient who's got a cardiovascular failure, is having a heart disease. Can you mute the participant, please? Okay. The second drug is misoprostol. It can be given as a 600 microgram dose. It can be an oral dose, a sublingual dose, or perrectal dose. The onset of this drug is 3 to 5 minutes. The peak action takes at least half an hour, and it lasts for 75 minutes. Can cause shivering or slight rise in temperature in patients who are having given misoprostol, but there are no contraindications except severe cardiovascular disease. Ergometrin, as I said, the duration of the onset is 2 to 7 minutes, and it lasts for 2 to 4 hours. But it can increase the risk of a retained placenta, can cause nausea, vomiting, headache, and can increase the blood pressure. It has to be avoided in a hypertensive patient, a heart disease patient, and in RH negative mothers. And regarding carboprost, the dose is 250 microgram IM dose. Onset is 1 to 2 minutes and can last for 15 to 20 minutes. It can cause vomiting, diarrhea, and bronchospasm, and definitely should be avoided in bronchial asthma. Regarding the choice of drug when you want to manage PPH, according to FIGO, oxytocin is the first-line therapy. Even if you have used the drug for induction, augmentation in the first and second stage, or you also used it as a prophylaxis in the active management of third stage of labor, still the first-line uterotonic will be oxytocin when there's PPH. The alternative, according to FIGO, is misoprostol, but it can cause more side effects compared to oxytocin, like nausea, loose stools, and febrile illness. Regarding the Canadian guidelines, the choice and the algorithm of how you need to manage PPH with uterotonics is, suppose you're given an oxytocin infusion or oxytocin slow IV, and there's an inadequate response. In the next 4 minutes, if the bleeding is not coming down, you need to move on to a second-line uterotonic. And according to them, sublingual or oral misoprostol, if it's given in addition to oxytocin, they say the combination works well. That is, a combination of oxytocin with misoprostol for PPH seems to work very well. Similarly, the combination of IM ergotamine and IM intramyometyl carboplast also works very well for the active management of PPH. But they say rectal misoprostol is not a very good drug for the management of PPH, and it's inferior to all other routes for misoprostol also. And there was a study which was brought in 2022 where they've said oxytocin is a drug which binds to a G protein coupled receptor, and it undergoes down sensitization upon repeated or prolonged administration. That's why if you keep on giving oxytocin infusion when the patient is hemorrhaging and it's not getting controlled, you need to change over to another uterotonic with a different mechanism of action, and that you need to choose early. You cannot keep on waiting for oxytocin to restore the uterine tone. But the choice of the second drug will be based on the institutional preferences and maternal comorbidities, because other uterotonics other than oxytocin will have more of side effects in the mother, and it will be usually a cardiovascular side effect. And always you have to give all the uterotonics in a very, very slow injection. Do not rapidly push the drugs because they can cause complications. And when you give it slowly, you can blunt these reactions. And methyl ergometrin and carboplast should be avoided in cardiovascular pathologies. And carbitocin is a drug which is a modification of oxytocin with a longer half time. And therefore, one bolus of carbitocin is usually sufficient. And the patient is hemorrhaging after carbitocin, it's better that you change over to one of the prostaglandins. Side effects of the uterotonics are usually systemic effects like hypotension, hypertension, myocardial ischemia, bronchospasm, and even death. And there's no clarity, like suppose the patient is not responding to a uterotonic drug. There's no clarity like that if you increase a dose, there will be a better response. So it's better that you change a drug rather than keeping on increasing the dose of a single drug, just not having the effect which you want. And oxytocin receptor desensitization is definitely a factor which happens. And if you give a higher dose of oxytocin, it may actually deteriorate the situation, which is already compromised by hemorrhage. And that's an emphatic statement. And this way, infusion should not be continued for a very, very long period if the hemorrhage is not getting controlled. Regarding NICE guidelines, the first line for PPH is oxytocin, especially in mothers who are hypertensive or preeclamptic. The other first line uterotonic is ergometrin, but it has to be given with caution in hypertension. And suppose a bleeding occurs during a cesarean, they say you can give an intramyometrial injection of carboprost, even though it's not licensed for use still. And suppose a cesarean is not done and a vaginal delivery has happened and the mother is bleeding with atonic PPH, you can give a intramyometrial carboprost through the abdominal wall. But if a significant atonic hemorrhage is still happening after the third dose of carboprost, it's better that the team consider transferring the patient to the operation theatre. That is, even after 30 minutes has lapsed after the first dose of carboprost, and you've gone on to the third dose of carboprost, and still the patient is bleeding, please transfer the patient to the operation theatre. Don't depend on the uterotonics now. And the previous guidance for oxytocin was an initial 10 units IV dose as a slow IV injection rather than the 5 units which has been given as a recommendation now. Now it is 5 units diluted in 5 ml and then it's given slowly. Initially there was a push of 10 units oxytocin and that was actually used as a prophylaxis. But in the 1997-99 report of the UK on the confidential inquiry into maternal deaths, they said profound hypotension was seen in mothers who was given the IV oxytocin injection without dilution, and that to the 10 units. And that's why the recent guideline has been changed to intravenous bolus of oxytocin is given, should be given very, very slowly in a dose of not more than 5 international units. And regarding the guidelines on misoprostol, when you use prophylactic uterotonics, misoprostol and oxytocin infusion have a similar effect. And regardless of the route of the administration of misoprostol, it can be vaginal, sublingual, or rectal. It actually takes 1 to 2.5 hours to increase the uterine tone. So you cannot rely on this drug for an immediate action of stopping the bleeding because it takes a longer period of time. But still, WHO and FIGO recommend it as the second line therapy for PPH, and they say a sublingual dose is one of the best routes for PPH. When you want to compare oxytocin against the use of other uterotonics, regarding the event of maternal death, there's no difference if you use oxytocin, carbetocin, or misoprostol. But when there's a PPH of more than 1000 ml, when you compare it with only misoprostol, it is actually more superior. Oxytocin will work much better to reduce a PPH which is more than 1 liter. But the combination of oxytocin with misoprostol, oxytocin with ergot, or ergot will have a better action to stop the bleeding compared to using only misoprostol. And the side effects are much lesser. Regarding blood transfusion, oxytocin is inferior to misoprostol and the combination of misoprostol and oxytocin when it's given as a single drug. And the additional, when you want to talk about the additional uterotonics, the combination of oxytocin and misoprostol is superior to oxytocin. And regarding the factor of mean blood loss and the occurrence of postpartum anemia in PPH mothers, when you give oxytocin with misoprostol or carbetocin, it is much better compared to giving oxytocin as a monotherapy. But regarding the side effects, it is one of the best drugs because the side effects are much lesser compared to all the other uterotonics. This was a WHO study which was done in 2018. So the take-home messages for the use of uterotonics is you can give oxytocin 5 international units by slow IV for PPH treatment, and you can repeat the dose. Or you can give ergometrin as 0.5 milligram IM by slow IV or IM, and that is contraindicated in hypertension. And oxytocin infusions are quite safe unless fluid restriction is necessary, as in a hypertensive mother. And you can go for combinations when you want to, when single drug is not working as a uterotonic. And the second line drug like carboprost can be given at a dose of 0.25 milligram, but only in IM dose. And it can be repeated only after 15 minutes to a maximum of 8 doses. and used with extreme caution in asthma. And in a patient where you want to give misoprostol, then you can give 800 micrograms sublingually. The rectal route is not effective because most of us use a rectal route, but it's not found to be as useful as we think so based on the Canadian guidelines. And if the pharmacological interventions like uterotonics are not getting control, it's better that surgical intervention is being taken promptly. Thank you so much for a patient hearing. Thank you.